So my name is Cathy. I'm a dietitian and I work here in the service. I'm kind of split between I'm mainly at the moment in the type 1 diabetes service, but also do some work in the bariatric service. So this presentation, I suppose, is on behalf of our whole dietetic team who would clinically work with the patients. I've themed the presentation around the common queries we get. So we get phone calls or emails, I would say weekly, if not more than once weekly, from dietitians particularly, or GPs or people usually working in the community who are encountering patients who've had bariatric surgery, usually abroad, but sometimes our own patients maybe who are being discharged from our services. So I'm going to talk about, I suppose, some of the common GI symptoms that come up and how to manage those and what's normal. Talk a little bit about targets post-surgery, micronutrient supplementation and deficiencies, which is something I think as dietitians we worry about a lot. What's normal for food consistency, options and portions. So just take you through where the person probably should be. And then I won't have a lot of time to go into kind of, I suppose, psychology of eating or managing expectations, but I'll make some references to that. But I think that was covered quite well by Ruth earlier. How does that sound? And we can share the slides as well after. Sorry, we should have said that at the beginning. So I have a really bad habit of putting too much content on my slides. So don't panic if you can't kind of read through all the content. We can share them later. So everything I talk about today is going to be, I suppose, underpinned by this key message we want to get from today, that obesity is a complex and chronic disease with I suppose lots of drivers and underpinning complexity. It's defined by health impairment relating to adiposity, whether that's excess or dysfunctional adipose tissue. And from a dietetic perspective, I suppose historically, a diet sorted it out, and that's not the way we think about this anymore. So it's about managing, not curing, like we think about lots of other chronic diseases. And we're good at this in lots of other areas. So there's something there about transferring our skills over. This is a really helpful resource, which is on the BOMS website, which is the British Obesity and Metabolic Surgery Society. Because what they've done is they've given a little bit of guidance to primary care about if you get a phone call from somebody saying, I'm having these symptoms, how you might triage that to some degree and decide whether you need to say to the person, I think you need to go to A&E or your GP, or we need to book an appointment. Helen will probably talk a little bit more about this, I think, later, so maybe we can come back to it, but that is on the website, and definitely have found that helpful, I suppose, over the last couple of months. So the types of surgery that you'll encounter, and again, Helen will probably talk about this in a little bit more detail. I suppose there's three main types. Oh, sorry, didn't mean to flick on. You'll rarely encounter gastric bands anymore, but then we have Roux-en-Y gastric bypass, OAGB, and a sleeve gastrectomy. They'll be the most common types you'll encounter in Ireland. And the reason I'm putting these up is, I suppose, just from a nutritional perspective, they are slightly different in terms of the kind of challenges or complications that can arise. So with the sleeve gastrectomy, we're particularly thinking about gastroesophageal reflux, and obviously that can, if that's a problem, that can impact on nutrient intake. And then in theory, the Roux-en-Y and the OAGB do have a higher risk of nutritional deficiencies because part of the bowel is bypassed. We treat them all similarly in terms of the nutritional supplementation, and I'll take you through that. But I suppose you might have a higher degree of clinical suspicion if you're seeing somebody who's had this type of surgery. The fourth picture over is biliopancreatic diversion. These are very rare, and even with people coming back from the European clinics now, we're not really seeing these. They use them more in the States. But I suppose they do have a significantly higher degree of nutritional complexity, deficiencies and protein energy malnutrition. So you're unlikely to see them. And the reason I suppose I'm going through this at all is sometimes in that first conversation with the patient, if they haven't come through the Irish system, your first job is trying to figure out what type of surgery they had, and they may not always know, and sometimes you're trying to get notes maybe that aren't in English and trying to figure it out and get them translated from there. But it is important, I think, to try and figure out what type of surgery the patient had, because it may influence how you assess them and how you manage that. So regardless of the type of surgery, I suppose you'll have some degree of restriction with all types of surgeries, and that will vary from 15 mils for a bypass up to maybe 200 mils for a sleeve. And that's primarily going to affect macronutrient intake. And then with some procedures, you'll have some degree of malabsorption, and that's going to affect micronutrient intake. And also it can alter food transit. So with some surgeries, you've problems with dumping syndrome and hypoglycemia. But I suppose regardless of the type of surgery, the challenge is we're trying to provide sufficient nutrition, macro and micronutrients for recovery to facilitate maintenance of lean body mass while people are losing weight. And it's quite rapid at the beginning. Steady loss of adipose tissue, supporting people to adjust to new ways of eating. And you've heard a lot about, I suppose, the psychological complexity of those changes, and prevent nutritional deficiencies. So there's a lot in that. There's a lot going on, I suppose, from a nutritional perspective. So I would always divide our goals into kind of two parts. One is perioperatively. So if you're not working in a specialist centre, you may not see a lot of this, or wouldn't have before, but if people are coming to you quite quickly from surgery abroad, you may see more of this. Perioperatively, our main goals are ensuring people are getting adequate protein, fluid and micronutrients, that they're progressing through these kind of stages with their food from softer foods back to solids, that they're on the right micronutrients, and the common complications would be vomiting, constipation, dumping syndromes. They tend to be GI complications would be the common ones at that stage. Longer term, your goals are, I suppose, supporting people to move back to a nutritionally adequate diet, 101 dietetics, no matter what we're doing. Longer term obesity management, and I suppose thinking about that in the broad sense, not necessarily related to body weight, but what I suppose the person's health. Monitoring for longer term nutrition deficiencies and the type of complications that may arise further down the line, such as hypoglycemia and weight regain. So some key nutritional guidance. So the main quantitative target around bariatric surgery is protein, and the general recommendation would be 60 grams of protein per day, or up to 80 or 120 after a DS. Sorry, a shorthand. That's the duodenal switch. That's that unusual type of surgery you probably won't see. Or if you have patients on hemodialysis, they will have higher protein requirements. And it's becoming more common for people to access bariatric surgery who are on dialysis because of some of the BMI limitations for accessing transplant. So in those initial stages, and even sometimes down the line, we would use oral nutrition supplements quite a lot to achieve protein intake. There'll be general guidance to avoid excess fat and sugar, and Susie alluded to this earlier. Often people's taste preferences will have changed after surgery, so can take a bit of exploring with the patient to see what's working and not working there. And adequate hydration. So we're aiming for about 1.5 litres per day, which certainly in these initial stages is quite tricky to achieve. So a lot of people would be doing quite well probably to manage a litre of fluid, but your target is 1.5. So that's the what. The how. So we will encourage people to have 5 to 6 small regular meals, eat and drink quite slowly, really taking their time with food, slowly progressing through these stages from soft to more solid. Keeping food and drink separate if possible, so prioritising food and the protein intake at the meal and then having their drinks after. It's really difficult when you're not used to doing that, drinking, have a glass of water or a cup of tea with your meal. And if people are having difficulties with food, trying to find nutritionally equivalent alternatives that they could manage. Really common one that people find difficult is white doughy bread. It just feels like it's stuck. Whereas people can sometimes tolerate it much better if it's toasted or maybe crackers. So if it's that kind of crunchier texture, that goes down easier. So again, just troubleshooting with the person, I suppose, to see what they're managing and what suggestions might work. So this is to give you some sense of, I suppose, our protocol here, and these will differ from unit to unit, but very broadly, there'll be 3 stages post-surgery. One is that liquid or pureed stage with food, then soft, and then back onto solid. Our protocol in this unit, and I think generally in Ireland and certainly in the UK, is quite a quick progression. So we would normally only have people on liquid for 1, 2, or at the most 3 days post-surgery. And we would use oral nutrition supplements and high protein milk in that period. And people would be getting small amounts, so it comes in at about 500 calories per day. Then when people go home from hospital for about 12 weeks, and this is again approximate, they would be having softer foods. And I'll show you a sample meal plan in a minute, but we would be prioritising protein, so things like scrambled eggs, yogurts, maybe some minced meat with a little bit of mashed potato, fish, chicken, high protein milk, and the ONS again. And we're talking approximately 1,000 calories per day. Some people will be lower, some people maybe a little bit more in that period, depending on how well they're tolerating food. And then as we get to about the 12-week mark, reintroducing fibre and I suppose looking to get more consistent more kind of solid consistency foods back in. So reintroducing fruit, vegetables and whole grains. And at that stage, the person is probably going to be in the 1,200 plus area if things are all going along well. There's some common question people have is particularly further on from surgery. So there's a high degree of restriction at the beginning, and then a couple of years after surgery, people will say, "But what should I be able to eat? You know, what's the right size for me?" And sometimes we'll talk to people about this idea of a side plate, but I think it varies a lot. And you will have people who can manage, you know, a dinner plate size meal. Did find a study which showed that at 1 to 2 years post-surgery, typical meal size is 50 to 60% of maybe what that person would have managed pre-op. So it's just to have some idea in your head if people ask you, like, where approximately are most people. But as I said, that does seem to vary. Very busy slide, sorry, but this is just our meal plan that we use with people here for that initial kind of middle stage. So people might be having things like egg or milk or yogurt with a bit of toast or quite a light cereal. Rice Krispies are really popular with high protein milk for breakfast. Snacks then would be yogurt, milk, maybe some Cubitan, cheese, meat, peanut butter. So prioritising the protein at that snack. Middle of the day, things like maybe some soft tuna or ham or turkey or eggs with, again, a little bit of bread or noodles or pasta that's well cooked. So it's not liquidized, but it's not very difficult to digest foods either. They're, I suppose, that softer side. An evening meal, maybe something like mince or chicken or fish or omelettes, and trying to get that high protein snack in again. So people will tell us it feels like you're just eating all day for those initial stages, and it's really, really difficult to get all of this in. So self-monitoring, so keeping some kind of tracker on it, really helps for those initial couple of weeks when people are maybe trying to build those habits or patterns back in. Expected weight change. Now, Helen again will talk about this, but it's very difficult to say how quickly people will lose weight, but it's a common question, and people will often say, "Oh, am I losing too quickly or too slowly?" It's really, really variable. We talk about this idea of approximately 30% absolute weight loss at about 18 months, and then you have this trajectory that everyone has mentioned of quite rapid weight loss, and then people will tend to regain after that 18-month mark or 2 years. Not everyone, but that's, I suppose, the average. So moving on to micronutrients then. Sorry, again, very busy slide, but I suppose depending on the part of the GI tract that has been either resected or bypassed, that will affect the type of nutrients that will be malabsorbed. And this probably comes back to where I was talking about knowing what type of surgery the patient had is obviously very useful for that. There is standard recommended supplementation after surgery, and this comes from both BOMS in the UK and Obesity Canada. So they do recommend, regardless of whether it's a bypass or a sleeve or it's an OAGB or YGB, that people would be on calcium, 12 to 1500 milligrams per day, vitamin D between 2000 and 4000 IU per day, and oral iron, which is kind of 40 to 60 milligrams of elemental iron, and then a vitamin B12 injection every 1 to 3 months, and then a general multivitamin, which is twice per day to meet all the requirements. So an A to Z multivitamin. And then we give some advice around trying to keep calcium and iron separate to maximise absorption. Nutritional biochemistry. So again, recommendations in that first year post-op is that we would be checking hematinics, folate, B12, U and E, and vitamin D quite regularly in that first year. They don't recommend checking zinc or copper or selenium that frequently, but they do recommend it annually after malabsorptive procedures. The additional considerations is if you had a patient who was vomiting a lot, to consider adding thiamine to that. And in patients that are symptomatic of anything unusual, and I'll come to that in the next slide, or if you've had that biliopancreatic diversion, they do also recommend checking fat-soluble vitamins in addition to zinc, selenium and copper. This is, it's too blurry and you probably can't see it very well. I've taken this from the Obesity Canada guidelines. It's a really helpful table which goes through some of the unusual symptoms that patients can present with. I suppose the ones you would be concerned about would be some of the neurological symptoms like gait or any kind of falls or those kind of symptoms that are unexplained by something else. So if you've somebody who comes and has had bariatric surgery quite a while ago, it's a good guide to maybe some of the less usual things, like when you might check for zinc deficiency or selenium deficiency or those kind of things we're not used to dealing with in the normal run of things. So that's a table we would use sometimes. In terms of treating micronutrient deficiencies, again, there is some guidance from both BOMS and Obesity Canada on how we would treat deficiencies. So I've highlighted in green, I suppose, the more common ones. So for vitamin D, people living with obesity will have higher requirements for treating low vitamin D. So the guidance would be up to 50,000 IU 2 to 3 times per week. Iron, we're talking up to 300 milligrams. And vitamin B, you'd increase the frequency of the IM vitamin B. So you'd still be given it 1,000, but it would be in increased frequency for a period. And thiamine then, about 100 milligrams 2 to 3 times per day. So it's about 300 milligrams per day if the person has prolonged vomiting. I wanted to go on to nutritional complications because I suppose these are things that you may be quite likely to come across in practice, particularly if people are coming from abroad in that acute phase. Most common one you come across is nausea and vomiting, and that's over 60% of patients will have some degree of this post-surgery. It's the most common reason for readmission because of dehydration. And I suppose in a planned service, we would do perioperative education on this and planning, and we would offer quite a bit of support to reduce the incidence. But if you have somebody presenting that's having all these problems, it's not complex dietetics here, so it's again things you probably would do with anyone that had this problem. So thinking about the stage they should be at, and again, if people come from abroad, sometimes they haven't always been given solid advice about what they should be eating, so taking it right back to those softer foods maybe initially, small portions, the food timing, so really taking time with food and spreading it out, fluid intake and trying to separate that from food, checking that the person is on a PPI, and that would be recommended post-surgery and can be really helpful with nausea. swapping foods that are poorly tolerated for something else. And as I said, if somebody has prolonged vomiting, considering thiamine, and maybe referring, if it's prolonged and it's ongoing, referring to a level 4 service for investigation, because they may have a surgical complication, or they may need psychological evaluation or medical input. Second most common complication we see is constipation. We find it in about 30% of patients, or even probably higher, to be honest, in practice at the beginning. It's a perfect storm. We have people reducing their fibre intake, they're on an iron supplement, and they may be on post-op analgesia and have slower gut transit. So lots of reasons for it to occur. We would increase fibre depending on what stage they are post-op. So a good example would be if somebody's having a lot of constipation, while we're not encouraging them to have something that has a lot of fibre, they might include something like a glass of prune juice or orange juice or a small part of a Weetabix at some point in the day, just to introduce some fibre. Trying to maximise fluid as far as you can and as far as the person can tolerate, but certainly targeting that litre and trying to push for 1.5 litres if possible. And use of laxatives. So we would give people a prescription for laxatives before surgery and say, look, this is really common, it's likely to occur, and we would encourage you to use laxatives if it becomes a problem as soon as possible. Protein malabsorption, or I suppose protein energy malnutrition, probably not that common after surgery. So the general literature will use albumin as a marker once they're not in an acute phase, and say it's between 13 and 30% of patients. There is malabsorption of protein if you've had any kind of bypass, and even in the sleeve you decrease contact with pepsin. So people are at risk, or they will malabsorb some protein. One of the reasons for that target of 60 grams per day, I suppose, is to try and allow for that. So generally we would find if people are getting 60 grams of protein in per day, this does not become a significant issue. It's probably more a problem with people who aren't tolerating, who are having a lot of maybe vomiting or intolerance. And again, just I suppose coming back to your dietetic skills, thinking about maximising protein sources and using oral nutrition supplements where you can or need to. Dumping syndrome. Again, probably not as common as the nausea and vomiting after surgery. So depending on the type of surgery, you can have loss of that pyloric sphincter, so altered transit of food through the gut, and then that can cause this vagal response. The main trigger seems to be foods that are high osmolality, so maybe high sugar foods or high sugar drinks that are absorbed quite quickly. So again, our dietetic counselling would be around trying to minimise those foods. Or sometimes we would encourage people to keep a food diary for a couple of days to try and identify what those trigger foods are and try and avoid them. But it tends to be, I suppose, transient if it happens. Probably the more serious version of this is a thing called hyperinsulinemic hypoglycemia. So this is where people are having very low blood glucose levels because their pancreas is overstimulated post-surgery. And you get it in about 10% of patients who are more than 1 year post-op. The treatments would be, from a dietetic perspective, small regular meals, lower glycemic index foods, and trying to stick to about 30 grams of carbohydrate at a meal. And the medications then would be acarbose, and there's a I suppose a pathway of care around this. If you had a patient who you thought was having this, our first advice would be to give them a glucometer and ask them to start checking their blood glucose levels. And if you identify that they are having blood glucose levels of less than 3 with symptoms, that would be a reason for referral to a specialist centre. And then there's, as I said, a kind of a pathway of care that would be overseen by the endocrinologist and the surgeon to try and treat that. To finish up, I suppose I wanted to give you a sense of our pathway here, and I suppose how we manage things from a dietetic perspective, and kind of mentioned some of this already. So in the pre-op phase, we'd be involved in the assessment for surgery. In the kind of 1 to 2 months before surgery, Claire talked about this, the screening with all the rest of the team, with the surgeons and psychology and the endocrinologists. So we'd be involved at that stage around education, around food and nutrition, and in that screening. And then about 2 weeks before surgery, we would do telephone support with patients, just checking in if they have any questions, and also checking about that pre-op diet, which I'll mention in a minute. Perioperatively, we'll do a review at the bedside at 2 days, and then we'll offer telephone support a week later, and ongoing telephone support if needed up until the person comes back to clinic, which is usually at about 6 weeks, and that's MDT outpatient review, so they see everybody again at that stage. And then it would be 6 to 12 monthly review up to 2 years at the moment. And we would use nutrition care process. So for any of the dietitians in the audience, they'll be aware that it's just a template for how we, I suppose, assess patients. So we just use a version of that for those patients, same as we would for any other patient. I want to mention pre-op diets because that's come up and somebody asked about this. So the aim of pre-op diets, or pre-surgery rather, is to try and reduce surgical complications and reduce the size of the liver, plus or minus weight loss. I would say that the evidence is probably mixed for all of those outcomes, but the general clinical guidelines would recommend that people do follow some kind of pre-op diet for probably 2 to 3 weeks before surgery. There's no evidence that very low calorie diets are superior to low calorie diets, so the consensus at the moment seems to be to use a lower calorie diet, so somewhere between 1,000 and 1,200 calories. Here in St. Columcille, as Claire said, we use a food-based plan for 2 weeks. People do have the option of meal replacements, and somebody asked earlier, we would just recommend Slim Fast as the default there. And we'd recommend a multivitamin and mineral supplement in conjunction with that for the 2 weeks. And just, I suppose this was a very recent study published this year from IFSO, just looking at what units internationally do, and we're kind of sitting somewhere in the middle. About 50% of units are using a low-calorie diet, about 40% use VLCDs, about 20% use very low-calorie meal replacements. So there's no right or wrong with this, but the majority of people, I think, seem to use a low-calorie diet for about 2 weeks, would be the average, again, pre-op. And just to highlight, I suppose, in terms of our outcomes, so Helen, who will be speaking after me, was involved in this publication in 2021, looking at outcomes from our unit. So this model that we deliver, where people have a lot of pre-op support, perioperative and post-op support, is associated with really good outcomes, low mortality and short length of stay, and very low readmission. And it contrasts probably a little bit if you look at, because patients will often say, I Googled it, and in the States people stay on liquid diet for months after surgery in some cases, but that wouldn't be standard practice probably on this side of the Atlantic, and we seem to still get the same outcomes. And just to mention this, Karen presented earlier on the model of care at a national level, and I suppose back in the day when Karen was working here as a dietitian, she led on our work with Vincent's. So when surgery devolved to Vincent's, we had to set up a cross-site care pathway for bariatric patients, because pre-op is here, their surgeries in Vincent's, and they come back here for post-op. So again, I suppose these things can be figured out, these pathways of care, which is something that we have to do now across the evolving community services. And when people have bariatric surgery, if they are being discharged after 2 years, how we figure that out with services. So it can be done. We've done it. In terms of longer term support, and this is my very final slide, and sorry, it's very wordy again. I suppose, when people think about obesity, they'll always ask about behaviours and where does behaviour fit, and that narrative is kind of there. So just to address that, I suppose there certainly is some evidence that consistency with these kind of behavioural plans, so whether they're activity or their nutrition or their monitoring, does minimise post-op complications. So we would recommend we work with people to develop plans and have those, minimising alcohol, monitoring their medical conditions, managing weight regain. And just to mention, I suppose, that there would be probably specialist periconceptual care if somebody becomes pregnant after bariatric surgery. Their needs would be different around perinatal vitamins and higher folic acid. And the health behaviours that are associated with improved outcomes would be weight checks, so self-weighing, a structured approach to eating, stopping when eating full, being physically active where possible or to as much as people can be, attending post-op support groups and avoiding binge eating. So I suppose we're always trying to find this line between supporting people's health behaviours and managing that complexity of obesity as a disease, and not trying to balance both, I guess. And that's it. Probably zipped through that. Sorry. Does anyone have questions? Ellen.
Do you feel we should be seeing these clients in primary care being abroad for surgery? Do you think they should be seen in primary care, or do you think they should be in a specialist centre?
So the question is, if people have surgery abroad, should they come to a specialist centre or be seen in primary care? So I suppose the model of care is there, and it is going to evolve, and I suppose all the granular detail isn't there yet. But in general, I think what it is suggesting is that if people have post-op complications, they obviously do need to be referred back to specialist centres. But if people don't have post-op complications, that we're aiming, I suppose, to try and manage that in primary care where possible. The tricky, I suppose, thing when people have surgery abroad is that, so in the current model of care, if you have surgery in Ireland, the advice is you stay with your specialist centre for approximately 2 years. But if people come from abroad, they're not necessarily linked in with a specialist centre in the first place. And currently there isn't resourcing, I suppose, to support that, unless people have complications, in which case, certainly refer in. And I think Helen will probably talk about that a bit.
So they can be seen, say, 10 days post-op from abroad, from Turkey or wherever, they could be seen in primary care, essentially, if those complications.
Sure, yeah. If the people feel skilled, I suppose, and supported, yeah. And we do offer, just to say that, I started at the beginning by saying I'm going to answer the questions. We get loads of phone calls all the time from GPs and dietitians. So we can offer certainly some telephone support around that. If you're just wondering, how do I approach this? How do I manage that? You know, we're a specialist centre, so that is part of our role to support you as well. Even if we don't necessarily take the patient, we can give you some advice around what to do. Yeah, loads of questions, sorry.
I just want to know, are there any kind of resources that you would direct primary care dietitians towards using in the community? So I think part of it as well is that there's not kind of the resources there to back up everything that's being said.
Yeah, I suppose from a nutrition point of view, BOMS is what we would recommend referring to, which is the British Obesity and Metabolic Surgery. The Obesity Canada guidelines are good as well, so they'd be the main two. We're adapting them actually for Ireland at the moment, and for the surgical post-op surgery chapter we're going to merge the two, so it'll be one resource to go to that will, I suppose, be a go-to hopefully. They should be available hopefully by the end of October.
And in terms of resources to hand out to patients, what would you recommend for that?
So again, we're happy to share our dietary information with people if you contact us and you want something to use, and we've certainly done that in the past before. Again, BOMS have some general advice on their website, as far as I know, that was developed by their patient council as well. It's kind of a tricky one because protocols differ from unit to unit, and you have this thing of not wanting to give advice, particularly if you don't know what type of surgery the person had or you're trying to manage complications. It's tricky. But I would say if you're stuck with the patient, call us, and we certainly can share our own resources with you, and that may be helpful in some cases. Yeah.
Cathy. So say someone has got the complications and we're thinking, it might be best to send them back to the specialist centre. Is that best if we write a GP letter and ask them to do it? Would that be better than us, writing the letter directly, or?
I suppose it depends on the complication you're talking about, but if you're talking about back to our level 3 service, we accept referrals from any healthcare professional.
Oh yeah, no, but say if it's say if there's something wrong surgically, or you suspect something, or they're dehydrated, that kind of thing.
Probably via the GP. Helen, would that be the advice, or?
Yeah, so then it depends on the acuity of it. For some of it is straight to an ED.
To A&E.
For instance, the surgical team on call for the most part to be able to guide on whether someone needs to come to ED versus an urgent clinic or visit here or a general surgery clinic in Vincent. So really it so depends on the patient, what they've had done, the stage of surgery, how far out they are. It's so hard to give very general advice.
Yeah. I mean, I think the more information you can come to us with, the better. So if you're picking up the phone to somebody or you're trying to make a decision, if you've done as much legwork with the patient as possible to find out what they had, how long ago, what the symptoms are, that probably allows whoever you're talking to make a better decision around triaging. So a couple more questions, yeah.
It's just in relation to if we identify that someone has a complication and we refer them back to yourselves, what kind of would be the wait time for that type of patient who is post-surgery with the complication?
So when you say complication, what kind of things are you thinking?
If they had kind of ongoing pain and ongoing vomiting, and maybe the GP's kind of looked at it and he's not sure what the next steps are.
Yes, so kind of maybe GI complication, we're not sure. It's not very acute, they're not persistently vomiting, they haven't gone to A&E. So generally within a couple of weeks if they're referred to clinic.
Okay, so very quickly then.
Yeah, pretty quickly, yeah.
Just in the interest of time, we'll do more questions at the end.
Yeah, okay. I think as well, Helen's probably going to address some of the questions you have around maybe the complication side. Okay.